Can you see the full screen or
No,
just
we could see the full screen before, not now.
before, right? Okay, just give me a second. Okay, yeah, now we can see the full screen, right?
Yeah.
Okay, hi, good morning and good evening to everyone through all time zones. So it'll be an interactive session, of course. I'm not an expert on cystic kidney diseases. Let me just put this here. I'm not an expert on cystic kidney diseases, but I'm just sharing my experience so far, which has been very interesting and enriching while doing this fellowship. So cystic kidney diseases are also called teardrops of the kidney, and very rightly so. And I'm going to start by a case. So this was when we're on call on inpatient service, we get all the consults, and there's a huge perinatal department and antenatal department as well. So whenever they do a level 2 anatomy scan and they find some problems with the kidneys, so they call us, and then we prepare them to be delivered accordingly, according to the problem, in consultation with the urologist if needed. And like everything is prepared beforehand, if it has to be a premature delivery or later on, depending on the problem. So this case, we got an antenatal consult for twins, one with oligohydramnios and other with twin-twin transfusion syndrome. So it was an baby was born at 35 weeks. Is this hindering everyone? Is this hindering? Is this coming in the way? I can put it here. So baby was an X35-weeker twin A who had oligohydramnios, antenatally diagnosed with polycystic kidney disease, likely autosomal recessive based on the appearance of kidneys on ultrasound. So when you get an antenatal consult and you see cysts on the kidneys, you're more than likely to jump up to the conclusion that it's going to be an autosomal recessive because it's presenting so early in life. Family history was significant for AD, autosomal dominant polycystic kidney disease, which was in the grandmother, the maternal grandmother, but the mother did not have anything. And there was a sister who also did not have anything. The baby had respiratory distress at birth, had to be intubated, had to be put on ECMO, developed pulmonary hypertension, and also went on CVVH because of that. Stable in room air after that. It started on Lasix and amlodipine for high blood pressures, and also for synthroid for hypothyroidism, which was detected on newborn screening. Then the baby started tolerating feeds, started tolerating PO feeds as well. The twin B, who had twin-twin transfusion syndrome, passed away in a few hours. Neurologically, it did not show any intraventricular bleed. There was no ventriculomegaly. Head CT did show small hemorrhages in multiple areas. Brain MRI showed there could be HIE and sequelae of that. Genetic workup was sent with prenatal consent. So there's two kinds of genetic screenings that we can do. One takes almost a year to come back, and one is research-based, which comes back in 6 weeks. Birth weight of this baby was 2710 grams. First ultrasound, since we had antenatally seen cysts on the kidneys, we went ahead and did a renal sonogram, which showed enlarged echogenic kidneys with absent corticomedullary differentiation and scattered punctate cysts throughout the corticomedullary regions, most consistent with autosomal recessive polycystic kidney disease. Abdominal ultrasound was stable. So of course we need to cover up the liver and other organs to look for cysts there, but there were no cysts on the liver. So this was like a situation, a confusing situation, because usually in such a severe presentation of autosomal recessive polycystic kidney disease, you expect other organs to also have cysts, but here there was nothing. And the family history was of autosomal dominant polycystic kidney disease. So when we did a genetics consult, they said that this is autosomal dominant polycystic kidney disease. But none of us were ready to believe that it can present antenatally like this. One of the twins can die. The baby has to go on ECMO with an autosomal dominant polycystic kidney disease because it's not supposed to be so malignant. Anyways, going forward, so this was the ultrasound. As you can see, these are multiple punctate echogenic foci in the kidney, both kidneys. So in the recent ultrasound, it showed enlargement of the kidneys. This baby was just a newborn and had a kidney adult size, 11.3 centimeters and 10.7 centimeters with, again, polycystic kidney disease. We didn't know which kind. Second case. So in the same week, got another consult for possible angiomyolipomas in a 5-day-old baby with tuberous sclerosis. So this baby was a 5-day-old, ex-full term, born to a 25-year-old, normal vaginal delivery. Pregnancy was complicated by multiple rhabdomyomas seen on the fetal echo of the baby. Fetal MRI showed presence of scattered hypointense nodules along the bilateral ventricles, which were suspicious for tubers. There was no prenatal genetics done. So this raised the suspicion for tuberous sclerosis, and hence they proceeded and went ahead with the full workup. Baby born unremarkable delivery course, was POing well. An echo in the nursery showed multiple rhabdomyomas, so neuro was consulted. MRI showed lesions consistent with TS, the candle dripping appearance, and dominant mass in the right frontal horn. So the baby was transferred to NICU. He started having seizures, and for management of seizures was transferred to NICU. Renal ultrasound was performed and showed few punctate echogenic foci throughout the cortices, representing cysts versus angiomyolipomas. Now, if it's angiomyolipomas, we were not going to do anything much because they were very small. So we're just going to repeat an ultrasound in 4 weeks and see if they have grown in size or not, and then do something if they have grown in size or if they're multiple still. But if they're cysts, it was a different story. So this was the ultrasound. As you can see, they're very small at this moment, and it's very hard to differentiate. So the right kidney measured 4.3 and the left kidney measured 4.6, which is normal for a full-term baby. There was few echogenic foci throughout the bilateral cortices. Case 3. So this was a newborn baby, day 2 of life, noted to have bilateral cystic lesions antenatally, now delivered, nephrology consulted after the repeat ultrasound, postnatally. Again, another presentation, whereas this one was a full-term baby, no complications in the pregnancy, so much so that OBGYN did not even think of consulting us antenatally, and we were just told after the baby was born that there were some cystic lesions noted in the kidney. The baby was 7.6 and 7.8. We wanted to monitor how the baby is feeding, what is the urine output. We wanted to get some labs, but the baby was perfect. Did not need oxygen, did not have any problems feeding. The baby was perfect, yeah. Liver also did not show any cysts in them. The right kidney was 8.3, the left kidney was 8.5. So this was said to be an autosomal recessive polycystic kidney disease on the ultrasound. Now, going back to the history of polycystic kidney disease, we have been plagued by this disease, this mystery illness since the 15th century. In fact, the first celebrity to die of polycystic kidney disease was the King of Poland. He developed chest pain and fatigue after a hunting trip. He died within 9 days at the age of 53 in 1586. And during the time of mummification, it was noted that his kidneys were as big as bull with uneven and bumpy surface. But of course, we did not know about polycystic kidney disease at that point of time. In the 18th century, polycystic kidney disease was thought to be hydatid cysts of the kidneys until someone came and said that no, they're false hydatids. They don't look like hydatid cysts. And finally, in the 19th century, the term polycystic kidney disease was used for the first time, and they stressed, Flix Lejars was the person who stressed that these cysts were bilateral and they caused clinically identifiable symptoms. So when you go on to classify polycystic kidney disease, they can be classified in so many ways because depending on the morphogenesis, depending on the clinical presentation, depending on the genetic makeup, that there will be no set way that we can classify them always. We will always be reclassifying them as and as we know more and more about them. So this is the classification that I read about and I followed, which was easier for me to remember. And this is based on the stage of development. So before nephrogenesis, if renal cystic disease are to be classified, then before nephrogenesis, it is multicystic dysplasia, which develops. Early during nephrogenesis, it is dysplastic kidney disease, can be just isolated cysts, or can be a part of syndromes. After nephrogenesis is when the autosomal recessive and the autosomal dominant both develop, the medullary cystic diseases come, and systemic renal cystic diseases come. Also, this very rare disease, nephronophthisis, which you just hear about, but actually haven't seen, maybe a couple of cases. Miscellaneous, you can classify as isolated cysts, acquired renal cysts, cysts within tumors, and cysts due to metabolic diseases. So multicystic dysplasia, as we all know, is the kidney really disappears after some time. And the diseases that we are interested in, polycystic, come after the kidney development has already taken place. As we know, there are two big forms, autosomal recessive and autosomal dominant. So we're going to talk about both. And both have a different genetic makeup. Autosomal recessive is the feared one. We in fact had a patient, whenever we are consulted and thinking of possibly an autosomal recessive, everyone sort of gets prepared for an emergency, that this patient will go on dialysis as soon as they're born. This patient will probably not survive. Even if they survive, they'll have very guarded prognosis depending on what happens. And everything needs to be done urgently. So whenever we're thinking of autosomal recessive polycystic kidney disease, as we were in our case 1, we get prepared that this is not going to have a good outcome. We counsel the parents accordingly, and we keep doing that. So the gene responsible for this is PKHD1. The incidence is much less common than autosomal dominant since it's a more severe disease, and also in utero, the fetus die a lot of time. So it is 1 in 20,000 births. Gene frequency is 1 in 70. Over 300 different mutations have been identified with different genotype-phenotype correlations. PKHD1 is located on chromosome 6, and the protein that they encode is fibrocystin or polydactin. This is grouped as a number of conditions called ciliopathies. So in pre- and postnatal ultrasounds, the kidneys appear grossly enlarged with increased echogenicity and reduced corticomedullary differentiation, as was the thing with both our case number 1 and case number 3. Just that in case number 3, there was no family history, and in case number 1, there was definite family history of autosomal dominant polycystic kidney disease. Renal cysts are confined to the collecting ducts and usually so small that their size in infancy is close to the resolution capacity of the ultrasound. So a lot of times, they might not even be picked up. ARPKD affects males and females equally and can affect all racial groups. It's a wide spectrum in the age of presentation, which correlates with disease severity. So not everybody presents antenatally, but it's said that if they are presenting, the earlier they are presenting, the more severe the disease will be and more severe progression of the disease will be. Those with most severe phenotype present in the neonatal period with oligohydramnios, pulmonary hypoplasia, and Potter facies. So we had oligohydramnios and pulmonary hypertension in our kid. Although ARPKD has been classically reported in childhood or adolescence, mild or late onset can present in adult life, occasionally as isolated heart failure. So the survival rate of ARPKD, it's not that nobody survives, it's just that depending on the presentation. So due to a lot of in utero deaths and late presentations also, the first month of life survival was 86% at 1 year. A second retrospective study showed that overall survival 20 years after diagnosis depended largely on the age at presentation, as we've been talking about. So if they presented at less than 1 year, then just 36%. If they presented between 1 to 20 years, then 80%, and more than 20 years, then 88%. That also means that their cysts are not that many and they're not disrupting the kidney architecture that much. In a study of 164 neonatal survivors with autosomal recessive polycystic kidney disease, the survival rates were 86% at 5 years, 71% at 10 years, and 42% at 20 years. So not all that bad either. Thus, apart from the severe neonatal presentation, overall survival is surprisingly good, which is something I learned while reading about it. Now, autosomal dominant polycystic kidney disease is an entirely different story. It is the most common form of cystic disease. The genes are PKD1 and PKD2. They're present on 16 and 4 chromosomes, and the frequency is much more common, 1 in 800 live births. With prenatal ultrasound, increased echogenicity of the renal cortex with corticomedullary differentiation, but the findings are not that specific or even well formed at that point of time. In these cases, a family study is helpful because in most cases, there will be a positive family history. Although autosomal dominant polycystic kidney disease can arise with de novo mutations as well, but still, if you have a positive family history and you have renal cysts, you don't need much more to make a diagnosis of the autosomal dominant polycystic kidney disease. So clinical symptoms of ADPKD are hypertension, progressive enlargement of the kidneys, and renal failure, and mainly seen in adult patients with more severe PKD1 related cases. In childhood, cyst formations can be detected in increasing number and size, which develop in an apparently normal kidney. So in babies, the main problem with the polycystic kidneys is that the kidney is so huge that they take up the whole space in their belly, and they cause compression of their lungs, leading to pulmonary hypoplasia. And then they develop feeding problems because of that. They need oxygen because of that. So a lot of times the debate is, when do you remove the kidney, or do you remove one of the kidneys to make space in the belly so that we can go further and then manage them, because there's no way to stop the growth of the kidneys in these patients. With ADPKD, they're mostly diagnosed when accidentally, as adolescents, coming out for something else, or with trauma, or with some abdominal pain, and then you notice that the kidney has cysts. And then you keep monitoring them for hypertension, proteinuria, because these are the disease markers for autosomal dominant polycystic kidney disease. If your hypertension, proteinuria start worsening, that's when you know the disease is progressing to end stage. So yes, cyst formation, coming back to the slide. Cyst formation is a developing process, and a significant number of children with ADPKD will not show cysts before second decade of life. Like they can have normal kidneys. They won't even know they have ADPKD. Renal failure is exclusively seen in individuals with severe kidney enlargement. So what other presentations can they have? They can have polyuria and polydipsia because of the concentrating defects. We'll talk more about that. Recurrent UTIs, hypertension leading to heart failure, portal hypertension because of congenital hepatic fibrosis, and progression to ESRD is common. All this is for autosomal recessive polycystic kidney disease. Here we talked about dominant, and this is for recessive. So they're, as we can see, they're both clinically independent entities presenting very differently. Now, tuberous sclerosis and polycystic kidney disease, there's the gene on chromosome 16, a lot of times there's an overlap between them. That's why you see polycystic kidney disease in cases of tuberous sclerosis, because when the gene is having a faulty formation, it just takes polycystic kidney disease along as well on the same chromosome. It's a very large gene. So renal cysts are relatively common in tuberous sclerosis, occasionally causing severe cystic disease and renal failure. Although imaging and gross features resemble dominant, the histopath appearances are distinctive and differing from both types of renal cystic disease. So the polycystic kidney disease associated with tuberous sclerosis, although it resembles autosomal dominant, but if you look closely at the pathology, it's a distinct entity in itself. But all the features are mostly with the adult polycystic kidney disease. Now, our case one, going back to the first case where there was a family history, and we thought that this baby surely has autosomal recessive polycystic kidney disease, and we consulted genetics, and they said it's not possible to have both in one family, autosomal recessive and autosomal dominant in one family. So this is autosomal dominant, and we were just not ready to believe, because this baby was so sick, behaving just like an autosomal recessive. The genetic analysis came back negative for autosomal recessive. So indeed, our first case had autosomal dominant polycystic kidney disease, which was a little surprising given the clinical presentation. So this is from the group of autosomal recessive polycystic kidney disease about how to manage them if they present in the neonatal period. So in newborns, massively, and whether to go for nephrectomy or not. I'm not sure what is the practice in India if you get a case of autosomal recessive polycystic kidney disease, but here every center debates, and this is the main point of debate, whether to do a nephrectomy. If we do a nephrectomy, when to do a nephrectomy, will it have improvement in the clinical features or not, and at what age will the child be able to go for a surgery like that also. So in this consensus guidelines that we have, it's the rationale for unilateral nephrectomy is based on a few small nutrition studies so that they can feed. There is no evidence that nephrectomy results in respiratory improvement. There is no evidence to support nephrectomy for severe hypertension in early ARPKD. So really they have sort of spoken against nephrectomy in almost all cases. But more often than not, clinically, we again find ourselves thinking about the situation and debating whether we should go ahead with a nephrectomy or not. A special subgroup of patients with autosomal dominant polycystic kidney disease may exhibit symptoms early in life, and it can be sonographically confused with ARPKD, as is what happened with our patient. Outcome in this subgroup of children with ADPKD seems to be better than in children with ARPKD. Now, surprisingly, uh, because one of the babies, the twin babies, died, and the other one had such a severe presentation, we were prepared to, and we kept telling the mom also that this baby is not going to survive, this baby is not going to survive. And now the baby is a year old, and I'll tell you what happened, because this was a very interesting scenario what happened. And his kidneys have also, for now, stopped growing. Classification in dominant or recessive cystic kidney disease, therefore, always requires family studies, because the outcome is so different. And ADPKD can be recognized in families. Also, we should know whether it's PKD1 or it's PHKD1, because the outcome is so different. Severe neonatal autosomal dominant polycystic kidney disease is rare and easily confused with recessive PKD. No wonder we were so confused. Managing such infants is often difficult and unsuccessful. A female infant with massive renal enlargement, respiratory compromise, and hyponatremia was treated with AVP2 receptor antagonist tolvaptan. This resolved hyponatremia, and there was no further increase in renal size. Now I'm throwing the hot potato in the discussion, which is tolvaptan. So as when we got consulted for these things, I was just reading around and then found out about tolvaptan in children. As we all know, tolvaptan is routinely used in adult patients with autosomal dominant polycystic kidney disease, and it is known to inhibit the cyst growth. Now, some interesting facts. When we see a polycystic kidney disease, I'm talking about autosomal dominant right now, we're not on autosomal recessive. So when we see a polycystic kidney disease, an autosomal dominant one, we see cysts everywhere, but in reality, it's only less than 1% of nephrons that are actually involved in the polycystic kidney disease formation. And even that number causes such a rapid cyst growth. So going to biochemical level and molecular biology level, the genes and the receptors that are involved are the CAMP, the mTOR. These are the two receptors that are actively involved in cyst growth and proliferation. So the mTOR inhibitors, something like bosutinib, have been tried and they have been unsuccessful in managing cyst growth. But, and the CAMP receptors works through the vasopressin, the AVP receptor 2. So they both combine together and then they work. Now, tolvaptan, as we know, is AVP antagonist, and it was actually used in patients of heart failure with dilutional hyponatremia for the management of the hyponatremia, because it causes free water excretion. This side effect on the kidney size and the cyst growth was just noticed. It was just by chance. So that was not the initial use. This was initially for hyponatremia that tolvaptan was used. But then they saw that it causes reabsorption of fluid within the cysts and decreases their growth. That's when it came to be used in adults. Now, for some reason, because we don't have enough studies and there's not enough trials, tolvaptan is limited to adults, but they have so far not been used in, especially neonates and children, to see what's the end result, because it can have a severe side effect of liver failure, and you have to manage the liver enzymes and monitor them very carefully. Now, I came across some case reports in more liberal countries like Europe, where they're more free to use drugs and try them out as well. So they came across quite a few actually. And there was this one female infant who used this, and they noticed that there was no further increase in renal size. Now you can understand the implications of this, that they used tolvaptan in an infant and the kidneys stopped growing. And so the child can grow, but the kidneys won't grow, and did not need a nephrectomy eventually. So now coming back to ARPKD and nephrectomy. So what are the fetal and diagnostic considerations? The standard second trimester ultrasound, which is the type 2 scan, if they show bilateral changes of large kidneys with poor corticomedullary differentiation, these findings are enough to suggest that it is autosomal recessive polycystic kidney disease. Macrocysts are more than 10 mm, and macrocysts are more common in autosomal recessive, whereas microcysts are more common in autosomal dominant. Extrarenal abnormalities. So there's other genes that have been associated with polycystic kidney diseases. We have HNF1B, which have other system involvement as well, such as the ovarian and the uterine system. And they also are related to the polycystic kidney disease. So these are the other genes, except for the PKD1, PKD2, and the PHKD1. Other syndromes are Turner syndrome, trisomy 8, 13, congenital CMV. In context of the severe oligohydramnios, fetal MRI may be able to delineate the renal anatomy, but it's not always done. So a complete 3-generation family pedigree, particularly adult onset renal disease and neonatal death related to pulmonary insufficiency or renal failure, should be taken as history in every patient of polycystic kidney disease. Ultrasonography of parents is recommended to screen for pre-symptomatic dominant cystic kidney disease, such as autosomal dominant or the HNF1, which run in families. Our case did not have it in the mom, but had it in the maternal grandmother. Now, how do we monitor? Once we know that there is a child with bilateral renal cysts, ultrasound should be performed every 2 to 3 weeks. Serial assessment of renal size and amniotic fluid volume. This is prenatally. And then gestational age at onset of oligohydramnios is variable. So we just, once we start noticing, it might be on the level 2 scan, maybe later, we keep monitoring them every 2 to 3 weeks for the size of the kidneys. Onset of oligohydramnios in the second trimester may be associated with pulmonary hypoplasia. Renal size more than 4 standard deviations in association, oligohydramnios was associated with 100% perinatal mortality. So that's why we need to monitor and then deliver before we reach the stage that there's a point of no return. So once the oligohydramnios is associated with, the mortality becomes very, very high. Prenatal imaging does not provide precise prediction for the development of lethal neonatal pulmonary hypoplasia. However, that being said, it does come with a precautionary warning. Now, how do we go for diagnostics for ARPKD? Now, ARPKD, as we were mentioning earlier, that you scan the liver as well for hepatic fibrosis and hepatic involvement, which is very common, and we develop the hepatorenal syndrome quite commonly. So finding large kidneys, you go for the liver, and if they have coexisting liver disease, this is usually sufficient for the diagnosis of ARPKD. Our case did not have liver involvement, but did have severe neonatal involvement, so hence the confusion. High-resolution ultrasound may improve diagnostic sensitivity, particularly in mild disease. Unlike in autosomal dominant polycystic kidney disease, kidney size or volume do not correlate with renal function in ARPKD. There may be phenotypic overlay between ADPKD and other cystic kidney diseases. So in autosomal, this is very important because kidney size and volume do not correlate with renal function in autosomal recessive. In some patients, serial observation may be required to make the correct diagnosis. Genetic testing we have to do. ARPKD expression can be highly variable with siblings. So you cannot for sure say that if this baby and this mom was supposed to have another child, they will have a doomed course. And the sister, if we remember, of those twins was normal, absolutely normal. Hypertension. The other elephant in the room is hypertension, whether we treat the hypertension, when do we treat the hypertension, and what do we treat the hypertension with in ARPKD. The prevalence of hypertension is very high, as much as 30 to 70%, and the mainstay is ARBs, ACEs and ARBs. Combination of ACE and ARB is not recommended, but ACE or ARB individually is recommended. Therapy should be directed towards optimizing blood pressure control while minimizing further reduction in GFR, as we all know that ACEs and ARBs can cause renal insufficiency itself, but they're still the best bet out there. We usually don't start them before the 6th month of life. So there was a multi-center ESCAPE trial of CKD, stages 2 to 4, that aggressive blood pressure control, whether you should control it, how aggressively you should control it, and whether it will correlate to end-stage kidney disease in autosomal recessive polycystic kidney disease or not. So they do suggest that you have to control blood pressure aggressively, and it may actually slow the progression, just like in autosomal dominant. Hyponatremia. So because tolvaptan is helpful, hence we know that when cysts are being formed, they form by water reabsorption in them and then cellular proliferation. So hyponatremia has been noted in autosomal recessive polycystic kidney disease, and the mechanism is similar to where tolvaptan works. The standard treatment is you concentrate the feeds without compromising on the nutrition. Supplementation with sodium is likely to worsen the hypertension and should be avoided. So we do not do that. It is not known whether the hyponatremia is due to excessive vasopressin or tubulointerstitial dysfunction, but the Vaptans are currently not recommended. Again, coming back to the tolvaptans. Differences between autosomal recessive and autosomal dominant. So far, we've talked about both in an overlap manner. Now let's talk about them separately and together. So the gene in ARPKD is PKHD1 or fibrocystin or polyductin. For this, it's polycystin 1 and polycystin 2 on 16 and 4. This is recessive, this is dominant. There can be de novo presentations. Family history is absent, usually present but absent in 10% who have new mutations. So you still go for genetic testing if you have a patient without family history. Age of presentation, usually neonates, usually an adolescent. Asymptomatic presentation is rare, very common. Enlarged kidneys are present. Enlarged kidneys develop in adulthood, variable in childhood. They more often than not have normal kidneys in childhood. Macroscopic is absent or few, they're present. Urinary concentrating defect is present in both. Hematuria is absent in this, present commonly in dominant. Flank pain, rare. Here it's present, most often due to cyst rupture. When these cysts rupture, they can cause some flank pain. Hepatosplenomegaly, present in this, very rare in autosomal dominant. Extrarenal cysts, absent, common. So in Berry's aneurysm in CNS, where you see cerebellar cystic lesions. Vascular or cerebellar aneurysms, mitral valve collapse, autosomal dominant. Progression to end stage, over 60% by adulthood. Here they have 50% lifetime risk, usually in the 5th to 7th decade of life. So here we know that it's a very slow decline of the kidneys, but here the decline is faster depending on the age of presentation and the size of kidneys. Now, differential diagnosis of other cystic kidney disease. Now, it's a huge, busy list, but some of the important syndromes I will talk about are other inherited syndromes associated with polycystic kidney disease, where we need to monitor for the same things that we monitor for polycystic kidney disease. That is hypertension, proteinuria, and progression to end-stage kidney disease. So tuberous sclerosis, the contiguous gene syndrome, is one of the syndromes where you need to do an ultrasound at some point of time to screen them and monitor them for the development of polycystic kidney disease, and also keep in mind the hypertension and proteinuria. Bardet beetle being another one. Von Hippel-Lindau, another big one. Beckwith-Weidman. Sporadic disorders, these are not that common, but remember tuberous sclerosis, von Hippel-Lindau, Beckwith-Weidman, and Bardet beetle. So this is talking about the other mutations as well. I'm just putting up different studies here to define PKD1 and PKD2 mutations. As we know, PKD1 is much more severe than PKD2. So there was a study in which 209 families revealed that 27% of probands did not have any apparent family history of autosomal dominant polycystic kidney disease as a result of de novo disease. Indeterminate family history in 10%, positive family history in only 1.9%. So if you see cysts on the kidneys and there's no family history, don't be calmed down by that fact, still pursue it, and it can still be polycystic kidney disease, but just coming out of a de novo mutation. So the guidelines for management of autosomal recessive polycystic kidney disease, the consensus, this is the reference that I used for our talk on hypertension, hyponatremia, nephrectomy, management of ARPKD. These are the guidelines that I used. And this is another case report about tolvaptan use in severe neonatal autosomal dominant polycystic kidney disease. One was the one that I described. And even in this one, they noticed this was in England. We actually got in touch with this doctor, and asked them about the outcome of this patient so that we could use the drug in our patient. And they said that this kid is actually doing pretty good, survived till 13 years, doing good, kidneys stopped growing, and they gave tolvaptan. But the things they monitored were, so we followed this and tried to use tolvaptan in our patient. Interestingly, what happened is, inspired by this, we started using putting tolvaptan. We didn't know anything about the drug, so the dosing and everything that we did was based out of this case report, that what dose they used and how they used it. And the outcome was, I don't know if it was coincidental, because we were not able to use the drug once the patient was discharged, because FDA did not allow us to prescribe it as outpatient, and multiple other things. I'm very curious to find out if other centers have tried it, are willing to try it, if they have seen something like this, or what has been the outcome. But we were only able to use it while inpatient for around a month. The kidney stopped growing at that point of time. Now, the grandmother was an autosomal dominant polycystic kidney disease patient on tolvaptan, and the mother was originally from Uzbekistan. So once COVID hit and we were unable to procure the tolvaptan as outpatient, the mother went to Uzbekistan and then used the grandmother's tolvaptan by herself. We did not have any role in this, and gave it to the kid, with working with a nephrologist there in Uzbekistan. And the child is now doing well. The kidney stopped growing in the infancy only, and now is more than a year old and doing well. So we don't really know and won't know unless there are some trials about tolvaptan. So yes, this is for PKD1. Yes. I just want to end with this, that dominant polycystic kidney disease is common and usually presents clinically in adults. Recessive polycystic kidney disease is much less common and frequently presents antenatally or in the neonatal period with severe renal involvement. These are usually thought of as clinically distinct entities, but the diagnostic confusion is not infrequent. Okay. Thank you.
Okay. Thank you very much, Ruchi. That was quite a comprehensive talk and some very interesting cases. So for the attendees, you can put in any questions onto the chat box.
Yes.
And but we will start questions from our own panelists. So first thing, Susmita Di, Jyoti Di, Shakil, any questions, any comment?
Shall I start?
Yeah.
Yes.
So, Ruchi, it's a really interesting topic to me. When I was training in US in the late 1990s, 96, 97, a lot of these discoveries were actually being made.
Oh, wow.
And we were also part of, there was a lot of groups in UK that were working on different components of PKD. And our hospital GOS was working very closely with the Oxford and the Sheffield groups, where the genetics were being done and the clinical patients were being, to a large extent, they were coming from GOS Guy's network. And my thesis was looking at ARPKD in the long term. So in the this was published in 97, and the patients were from the 1950s.
Oh, so they survived in years.
It was looking at neonatal survivors. It was patients who had survived the neonatal period. ARPKD, survivors of the neonatal period. And we had figures a bit like what you showed. So like 86%, when you looked at actuarial survival curves, 86% survived over 1 year. And I don't remember the details. And so on. So it wasn't as bad as you would expect over the neonatal period. The other two interesting things were that with time, the kidney stopped growing. So there was a very nice curve that we generated showing that the kidneys were really big to start with. And then when you look at the kidney centiles, the size centiles, it dropped off.
Did you know like what age? Was there a certain age with all of the patients that they stopped growing at?
I'm sure it's all there. There was an actual, a graph showing you what the actual growths were. So I can send you those references. It's a very old paper now, of course, but it was very fascinating at the time because we had grown up thinking that ARPKD was a life sentence at a very early stage, and we saw that it wasn't at that time. Secondly, hypertension stops being a problem after the first few years. So both kidney size and hypertension becomes easier to deal with time. So that was number one. But the even more interesting was that the majority of these patients who had been diagnosed in the neonatal period and had been followed up for this length of time thinking they were ARPKDs, during around that period, 95, 96, 97, they all started getting their genetics done, or maybe a little bit later even. They started getting their genetics done. And the interesting thing is that many patients that had been labeled as ARPKD all their lives were actually ADPKD.
Yeah.
But they were similarly with huge kidneys, with oligohydramnios, and that whole gamut.
Yeah, exactly. Like this case, it was so strange.
It was kind of coming alive, that this whole topic at that time. Then the other very interesting discovery this whole group made, and it was based on one of our patients from GOS, was that this big family who had ADPKD then had a daughter who had tuberous sclerosis type symptoms in science. And that was when the contagious gene deletion was discovered. It was an ADPKD family, but this kid particularly had that whole contagious part of the chromosome 16 deleted. So she actually had tuberous sclerosis as well as ADPKD. So very interesting. I think you could go through the history, how things have evolved with time, the mistakes people have made, and how much more we know about these diseases. And the final question I want to ask you is something we struggle with. The adult population is using tolvaptan a lot on patients with ADPKD whose kidneys are growing massively, etc. We often have kids sort of approaching adulthood, adolescence, say 14, 15, 16.
An article, yes.
Yes, what is being done in your center with these kids? What do you base your decision to treat with tolvaptan on kids? Do you do serial MRIs or do you just do ultrasounds? What do you do?
So unfortunately, America is not a liberal country where you can go ahead and implement ideas. You need a lot of proof. There's lots of FDA regulations even to use drugs. Like we struggled using, this was a neonate that, we sort of illegally did it. But inpatient, it was not a problem because the pharmacy is ours. But outpatient, we tried to get tolvaptan for multiple patients. One was 16, one was 15. It was a failure. Like, no, we were not able to. So they have to be more than 18 years, and FDA approves it only for more than 18 years. They just don't allow it to be used. So in spite of many, many efforts, and the only way we can go around it is by having an only NIH funded trial, by using it, and that too not in children, only in adolescents. So now C. Jason has come up with this recent July 2020 article for C. Jason. So they actually talk about tolvaptan in adolescents. So I'm just, I will send you this, but they are the ones who've started using tolvaptan in America in adolescent populations. And I'll send you, this is very recent work. But before that, it's not being done. It's only being done in pockets here and there in patient hospitals or where they have been able to do it for individual cases.
Kind of the same indications as the adults, like rapidly growing kidneys and
rapidly growing kidneys. Yes, rapidly growing
So,
kidneys.
in the
sorry, go ahead.
Sorry, you complete and then.
So they have also said that if because it's related to kidney size, the presentation. So they said they can slow the progression to end-stage kidney disease by using tolvaptan earlier, which I believe in. But again, yes, it's a long journey.
So the problem is that when to start tolvaptan in pediatric, we don't know at the moment. Because we don't have any studies which have really followed up this total kidney volume as per normalized to the length in pediatric age group.
Yes.
which have done that in a more scientific way. One of my friend with whom I was doing my fellowship, my training in Zalila Makhali. She's in Belgium, and there they have a group who is interested in uh, very early onset ADPKT, VE ADPKT.
Just like
And they have started a study where they are using tolvaptan among the children with ADPKT. So at the moment, it is still investigation drug.
What age have they started?
They are starting like right from early onset. Early onset. So
and how
you
are they
can
monitoring? Like that's very interesting. Like how
you
do
can just you can just Google it on, and their whole protocol is on their website, and
really?
and they have their own group. I think it is VEADPKT or VEO something like that. And their whole protocol, there is a big group on it, and Zalila is one of the leader in it. Just a comment on TCS and ADPKT. So I have had one children whom we had proven to be a contiguous gene syndrome. We published that case in NDT Plus few years back. And at the moment, that last year we had a child exactly as you described.
Oh, really?
Like,
The first one?
Yeah,
22?
exactly like antenatal diagnosis of rhabdomyoma, and then subsequently after birth, we did a MRI, and there were tuberculosis, and then there was renal cyst, and we went ahead with the genetic, and it came back as tuberculosis gene. And now, if you're wanting to look for whether it is contiguous gene syndrome or not, that will not be disclosed by your NGS. For that, you need to go for microarray, because that's a sort of a deletion. So that NGS can often miss. So I was very excited that this might be our second case of contiguous gene syndrome. So we spent the money for microarray, but it was not. So tuberculosis can itself per se can have polycystic kidney disease, or it can be a manifestation of contiguous gene syndrome. And what literature says that if it is a contiguous gene syndrome, then the outcome is supposed to be more worse than the cyst just arising from the tuberculosis. And why do they have cyst? As you all know that because tuberculosis is also a disorder of the cilia.
And mTOR inhibitors work. Yes.
Yeah. So that's why they can have cyst. Another point, another interesting thing was we had this year we had a baby from Bangladesh who had come with ARPKD and had a refractory hyponatremia. Refractory hyponatremia with hypertension.
Yeah.
And we really struggled with the child. We were thinking of using tolvaptan, but what we did was fluid restriction, hoping that it will improve. But then the fluid restriction which was improving the sodium was ridiculously very high fluid restriction, like practically you'd be compromising the child's growth. And then we were thinking of tolvaptan, but then they went back to Bangladesh, and after that with the lockdown they haven't turned over. So but tolvaptan is something that we are using it, but very in India you can use anything, but,
exactly.
not officially.
Would you try to do it in adolescence? Would you be like?
Susmita ji, have you used any of it? Susmita ji, where is she? Susmita, yeah.
So So my older kids, I've spoken to my adult colleagues and they say, yes, of course, we are using so many and nothing happens. So I was worried about would they get polyuria and get dehydrated, etc. So they said, no, nothing happens, just give it, etc. But so that's why I went back and looked up all the data and the recent guidelines and that have been, that have been published, etc. So it seems to be very clear that you need a lot of investigations to first document that the kidneys are growing rapidly.
Exactly. Yes, I've stopped growing.
So
Yes.
my first question is, how do I confirm that? Just ultrasound. What they are suggesting is
We did only ultrasounds with this baby.
So,
Monitor.
To look at volume on MR.
So there is a recent publication where they have sort of shown that ultrasound, the total kidney volume calculated with ultrasound can be used as a surrogate marker equivalent to MRI. There has been a recent publication. So that's but then again, the problem is that in our system, we don't have an institution. So who is doing the ultrasound, and that person has to be sort of made excited that yes, this is something that you should be excited about, and try to learn how to do the total kidney volume from the ultrasound, and that same person has to do it every time. And in big hospital, for example, in Apollo, their head does not, the Apollo's radiology head does not encourage any of their radiologists to be specific of any imaging. She strongly believes that all radiologists should be looking after everything, like starting from, and their consultant also gets a rotation, like CT, MRI, ultrasound, all rotation. So it becomes very difficult there.
But I think if I had a child who was very clearly showing marked enlargement, serial ultrasounds even showing very marked enlargement, with whatever parameters we use, I would probably then talk to the parents, give them the option of trying it. But I haven't been in that scenario yet.
I have had 2-3 children who now I can remember, and they were all like 80 pkd. So I'll just give it to 2 or 3 interesting scenarios that I've encountered. One was a child who came in with hematuria, and then we did an ultrasound scan. Ultrasound scan showed right-sided cystic kidney disease, left side nothing. Right-sided cystic kidney disease, large big cyst and enlarged kidney. I was confused. So we did, it looked like a multicystic dysplastic kidney, I thought. It must be a multicystic dysplastic kidney, although at that time the child was 4 or 5 years old. And so why is the multicystic dysplastic kidney still persisting and so big? So we did a DMSA scan. We saw that the kidney was functioning. So and then we did a genetic study. Genetic study showed that this child had a ADPKD. ADPKD with a unilateral cystic kidney disease. Now this child is under follow-up with us for 3 years now, and the kidney size is growing. So this is one. Another child who has a family history of mother has ADPKD and the child presented with nephrotic syndrome. So initially I thought that maybe this proteinuria is because of the cystic kidney disease, but then it was a frank nephrotic syndrome, and the child also had a polycystic kidney disease bilateral, and the proteinuria responded to steroid. So most probably this child had a nephrotic syndrome, was like double unlucky, but had a nephrotic syndrome as well as polycystic kidney disease. I referred this child and the mother to the adult nephrologist, but our adult nephrologist, both in Fortis and in Apollo, the senior adult nephrologists are more conservative. Both of them said that no, there's not much evidence on tolvaptan. Tolvaptan has got side effect, and there is a school of thought that whatever use tolvaptan has is primarily because they drink lot of water, because they make you polyuric and lot of water, and there is some studies which shows that drinking lot of water also helps polycystic kidney disease. So they refused to start. Another child, another baby I have who was a neonatal, just like you said, a neonatal presentation with bilateral cystic kidney disease, and I was sure it will be ARPKD, but then came out to be ADPKD. With and it was genetically proven. So all these cases makes me want to start them on some treatment. Yes. Because when if you're following them up continuously, what are you telling them? That why are you coming? I'm going to tell, yes, your kidney is enlarging, and in future you might be in problem. Then doctor, why are you not giving me anything? Well, the maximum I can give you is NRFL. But at the moment, I spoke with some other doctors in India also, like seniors, and most of them said that we are not using tolvaptan ADPKD. We in our institute we have used tolvaptan in nephrotic syndrome. Now, Sakil, we have used it 2-3 times in nephrotic syndrome with severe hyponatremia, and we have used tolvaptan in SIDH, but still yet we haven't used it in ADPKD.
Maybe now, if you do, please, I would love to be involved, because this would be such a, it's not being done anywhere, and it's such a problem to get people to start because of the side effect profile that they worry about, a liver failure and the monitoring of electrolytes, and also this word that it might not even work.
If you can get the funding, we can definitely start.
Okay.
Okay, I have a question.
I'm very serious about it. This is like,
I think, what do you think is the hypertension, the kidney starts growing firstly, I mean, it enlarges its size first, and then the hypertension starts, right? So, so it's often that when we get the children, I mean, they come with one ultrasound. I recently had a child from Bangladesh whose mama was, they never told me what the mama was suffering from something. So the child had they just came with pain abdomen or something like that. And a lot of probing and things like this, they ultimately brought out an ultrasound, and I saw there was a cystic kidney. So and there was a urine routine, and the urine report which showed some around 1+ proteinuria. So I did the blood pressure when it was high. So then a lot of questioning, then they said that the mama was suffering from a kidney disease, and he had come to show some nephrologist in Kolkata, and but they didn't. Then the mama came in suddenly after showing the other doctor, and he said that he was suffering from ADPKD. So now these children obviously would not stay, they would go back. So for them, getting serial ultrasounds is almost impossible. So if you get hypertension, means already the kidney has started growing in size. So I mean, it is in that stage already. So what in those stages, patients, monitoring, I think, is the most important problem that we would face if we start with tolvaptan. I mean, just giving them, starting it off and then monitoring, not being able to monitor, because they would probably not come back. They would be going to their local place, wherever in Bangladesh or wherever. So those problems will be there. The levels, the sodium levels, or whatever is actually coming. I think that, I mean, in our country, I think that is the most problem we'd face even if we get the audacity to start off with tolvaptan in these patients. Rajiv, what do you think? How would you monitor these patients if you started tolvaptan?
Yeah, I mean, as you said, that if they are coming from far off places, it will be difficult. So tolvaptan, we are usually, wherever we have used it, for example, we are using it with this child with SIDH, and initially we have monitored it very closely, like every week we are doing some bloods, but ultimately it will be maybe once or twice a month. And you also have to monitor the LFT, because apparently tolvaptan has got a serious side effect on the liver function test.
So
that
how
was
is
one of
this child doing, Rajiv, the SIADH child?
The sodium is quite stable now, 130, 132, but the child has a COVID.
Oh. But it means that it's not a renal syndrome then, it is secondary to something.
Yeah, we don't have the answer. We have also been joined by Subhankar, so if he can hear me and if he has any questions. Subhankar?
I'm sorry, I'm busy road, I'm driving.
Okay, Subhankar is driving and doesn't have question nahi to?
No, I put a screen
ठीक है.
I just log in. So
Okay.
I'll see the video. Thank you so much.
Okay,
I think it will be a nice discussion going on. I'm just listening to you.
Subhankar is our new faculty who has joined in ICH. He did his training from AIMS and then year in Singapore. And he has joined maybe 6 months or so.
Oh, great. The team is growing. This was very good. This was very good for me also. We should do it more often, maybe once a month.
Ruchi, one more question if you have got the answer. Like, what is the reason for the hyponatremia in this ERPKT?
The same that they say. The same reason that they say that the cysts form. It's the same reason. Why tolvaptan works? That because of the cyst enlargement and tubular growth, so they cause water reabsorption within the cysts and causing manifestations of hyponatremia. But it doesn't happen in everyone. It's not that common as.
Yeah, but it can be real. Like these. We have seen this child, and then this. I remember seeing 2-3 children in UK. They were really refractory and very difficult to manage.
So I just want to add one point here.
Mm-hmm.
So actually, in the ARPKD has a lot of refractory hyponatremia, not much like in ADPKD. The cause, I read one article that they mentioned that it's due to the leaky tubule actually. So tubular dysfunction most likely.
Yeah, that's what they absorb the water. The cysts, when they're growing, they cause intracystic absorption of water. That's how tolvaptan works also. It inhibits that mechanism with the vasopressin, arginine vasopressin receptor. So that's how it causes the hyponatremia.
And the other confusion, which is because we were at the moment we are thinking of doing a study in India, looking at childhood onset ADPKD, like a sort of a questionnaire study. Because I got interested in this childhood onset ADPKD because of all these cases that I have been seeing, and all of them or many of them turning out to be ADPKD rather than what I thought ARPKD. Just like Susmita, they were saying that and more and more papers are also coming out that ADPKD may not be just adult onset or a late onset thing. So the difficulty that we are having with this in the studies that how do we define ADPKD in children, because many of them, like all centers, do not do genetics. Many of them do not have financial capability of doing the genetic study. So that something is a major problem, because this definition of ADPKD that we have at the moment is for children 15 years and above. But for 15 years, so if you have any idea on that, or if you can find out anything, then do tell us. So Smita, any idea like how do you define
the major, if you can't do genetics obviously has to be the sort of final endpoint. If you can't do genetics, it has to be family studies.
But then the
and often if the parents are young, you might have to check the grandparents also.
Exactly.
Yes. Okay.
So the problem is that many a time, if you're like for newborns, parents are also young, and many a time grandparents are not available, and then they are.
One more thing is that at the end of the day, it doesn't matter what the disease is, because the management is, getting the child respiratory status stable, controlling the hypertension, controlling the proteinuria, etc. You can make the diagnosis later on also. There is no huge urgency to make it.
No, I was speaking about...
Whenever we can get parents, grandparents, whenever we can manage to get some genetics done, it's okay to wait. Because it won't make a major difference to current management. It will make a change to the parents' decision about conception and another child and that kind of thing, and to our maybe prognostication, what will happen in the future.
Prognostication is important, yes.
Yeah, but
yes.
immediate management probably won't change, no? What do you think?
But what Sir is saying is also correct. Like there are more and more cases coming at earlier and earlier age, as we didn't know earlier, which was not known earlier about ADPKD, that they are now presenting like ARPKD, but turning out to be ADPKD.
And my question was more like if we are wanting to do a study on it, like trying to see the status of childhood onset ADPKD in India. How do I define that group? That has been a
for a research article. You have your basis has to be genetics. There's no other way. So if you want to get all neonates with big hypoechoic kidneys, and then you want to see their outcome, then to classify them, there is no other way other than genetics to classify the etiology.
Exactly, that's where the problem. And the problem with genetics is that often just doing the child's gene is not enough. You have to do the parents also. और ये सब में तो पैसा लगता है ना. So that becomes a, although it is much cheaper than what Ruchi was saying it is in US, but still it is quite costly in India. Any other question? Anyone else? No. So thank you very much, Ruchi.
Thank you so much.
Has to ask a question, no? That's
one question to Ruchi. Ruchi, anybody, any of you in any centers, are they using somatostatin?
For ADPKD?
For ADPKD, for the same reason that they use it in polycystic liver disease. There was, I think, some papers in this regard that, the using of somatostatin. So,
we're actually using somatostatin in FSGS, like ACTH and FSGS, but not in, no.
Not in ADPKD.
Not in polycystic liver disease.
Okay, anything else? Otherwise, thank you. And
just please send us your email address to Patli.
And keep in touch with us.
Yes, of course.
And please do try to find that funding. We are always eager to give the cases to you.
I will try. I'll definitely try. I'll find out about it.
Okay, then. Thanks.
Rajiv, why don't we add Ruchi to our ICH Pediatric Nephrology WhatsApp group so that she knows when our
yes, I would love to attend.
And if she's free,
yeah, that will be very nice. If you can give
we are having teaching at the moment. It is all online. We have it on Monday and Friday, exactly around 5 to 6. Because after 6, you remember Pahari Dana, Amitabh Pahari. He is unable to attend. That's why he couldn't attend today, and he's one of our most senior persons, so we want him to attend also. So usually it is 5 to 6.
Okay.
Monday and Friday, but so we'll I'll ask Adita to add you to the group so that you can join whenever you have time and give your valuable opinion, because that will be really useful. No, it is always good to hear what the Western world is doing, so that we are not very far behind them.
That's one. I just have not a polycystic question, but I remember when I was training, we used to always debate about fluids, like why are we not using isotonic fluids in children, just for regular, whenever they come for regular volume expansion, why do we use D5 half NS? And here there was a whole guidelines came last year about fluid resuscitation in pediatrics, and they have actually recommended using 0.9 of normal saline in all children older than 3 months of age. But once that started happening, actually, what we found out that we started getting consulted hypertension a lot, and then one of the nephrologists, the ASPN, I think director, wrote to them that this is not for children with kidney problems or any kind of kidney problems. For them, we still use half. We have to use half NS. We cannot give them that sodium load. So what are you doing in India about? Are you using for regular volume? You're using?
So if you remember, you were not remembering correctly. When you were in India at that time, the people were using isolite.
Isolite, yes.
That is not half NS. That is 1/5. 1/5. So we have come out from that. Now most of us are using half DNS.
Half DNS, yeah.
Half,
half DNS.
Half DNS, but for nephrology, it was always there that this guideline of using normal saline was not for nephrology, not for DIP. So those were the exclusions which we had. But yes, now most of the, at least in the cities, I believe most of us are using half DNS. Thank you.
Thank you.
Right.
But we do come across cases where everybody's using normal saline nowadays for everything. Okay.
Yeah.
But we do come across cases who are, who have DI for whatever reason, and who, with all this normal saline are getting, as you said, hypernatremic dehydration, etc. So I think, as Rajiv said, the exclusions are there in theory, but have not really penetrated into the minds of all general pediatricians.
Yeah, we had one child. I think it was in Apollo. I don't remember, Apollo or Amri. Not under us, but a child with DI convulsion. They gave normal saline, and then convulsion went on getting worse. So it does happen.
Oh, okay. Thank you. Thank you so much.
Okay, thank you very much again.
Thank you.
And do join in our group whenever
Yeah,
we have time. We will put you in.
Thank you.
Bye.
Thank you. Bye.
Bye.